So I request Dr. Partho Goswami to share his screen. Dr. Partho, we cannot hear you. Please unmute yourself.
Good afternoon, ladies and gentlemen. I bring greetings from the beautiful city of Kolkata. Those who have been here will savor the memories of a winter in this wonderful city with a fantastic history. And those who have not been here, I extend my arms to have a small visit and enjoy the sights and sounds of Kolkata. The topic for today's discussion is the coronavirus and the anesthesiologist in practice. Now, this is a little bit about me. Been working at the Partho Neurosciences Center at the Partho Clinic for almost 2 decades now. Haven't moved too much. And we've done a substantial number of cases of neurosurgery, spinal surgery, and plenty of neurointensive care. Now, according to me, the history of human existence can be conveniently divided into 2 parts. And this is a recent development. I call it BC, not before Christ, the conventional thing which you know, but before Corona, and AC, which is after Corona. And I've even conveniently divided the Corona epoch into 2 parts, BV and AB, which is before vaccination epoch and the after vaccination. And as all things in life, the coronavirus has left a very deep mark in every aspect of human existence, whether it's medicine or anything remotely not concerned with medicine. And as you can see here, very, very clearly, how the Nikkei and the Dow Jones and the London Stock Exchange have crashed substantially because of the coronavirus and the trading inequalities. However, as we look at the flip side of the story, as we began to battle the epidemic, learn a few lessons, adjust ourselves, readjust our lives, the stock markets have also begun to pick up over time. And like all things, the bounce back is more important than the fall. So who is at risk for the coronavirus? It's a very popular saying that COVID-19 is not an equal opportunity killer. It kills certain selected individuals. And this is a fantastic graph which tells us who is more vulnerable to the COVID-19. You see 76.7% of all deaths that have happened in the COVID epidemic have happened in those who are above the age of 50. And this is an alarming statistic which tells us very, very clearly that the US deaths from COVID-19 match the toll of the 3 major wars which the US fought, which is the Vietnam War, the Korean War, and of course the World War II. Believe me, some alarming statistics are still beginning to emerge from the pandemic across the globe. And this year, as of December 2021, the COVID deaths exceed the annual death toll of HIV, tuberculosis, and malaria. Now that sends alarm bells ringing all over the world, in every nook and cranny, in every household across the nation and this big country of ours. So when the COVID came, how did we adjust to it? This is a funny slide. The first phase was, oh, it's just another passing viral scare. Then they said, oh hell, this is getting a bit heavy and serious. Then it was, oh my gosh phase. Life is being turned upside down. Finally, Once we know where your apples and oranges are, you begin to say, let us tighten up our seat belts and gear up against the enemy. Finally, when the shots were given, the vaccination came into existence, we began to say, all right, let us readjust our gears and keep this battle alive. It's a battle for existence. It's a battle more fought than the battle at Waterloo. Therefore, we actually did not know what was the true path, what was the correct path. And the only thing which we knew was there was uncertainty ahead. Uncertainty in professional lives, uncertainty in personal lives, uncertainty in the socio-economic existence of human beings. And as we know, in this wonderful article from Anesthesiology, that anesthesia care providers are uniquely positioned to be at very high risk for development of COVID infection. Now that does not make you feel very comfortable at any cost. But we knew we had to follow one Charles Darwin. Charles Darwin had a correct observation when he said that it is not the strongest of the species that survives, nor the more intelligent that survives. It is the one which is the most adaptable to change. And over time, we have changed the way we practice neuroanesthesia. And we have adapted to the uncertainty of the coronavirus. So what did we do? We designated a COVID OT and access to it. We had an elevator for suspected and confirmed cases and desegregated the central air conditioning from the operating room. PPEs became a way of life. Masks, gloves, eye shield, and we had minimal operating room traffic. It was like fighting a war against the unknown enemy, the unseen enemy, the unforgiving enemy. The team was led by the senior most anesthesia provider. We tended to avoid somebody above the age of 65. And because we had minimal operating room traffic, we had only one technician for help during induction of anesthesia. It's very difficult to form a designated team. We had teams in rotation of 4 days on and 3 days off. And there was an absolutely clear allocation of roles and responsibilities to every single member of the team. We made it a point to practice correct donning and doffing of the PPE apparatus. The correct donning and doffing sequences are here for you to see and for the juniors to follow, because this is going to be there for some time still before it marriages into a peaceful existence with the human beings. So once the patient came for an operation, we had a rapid assessment of the patient from the cardiovascular point of view. We had minimal personnel in theater. And we realized over time danger of COVID transmission. Therefore, it was at this point of time when we were in business, as we called it, folks. We have protective N95 masks, we have industrial gas masks that we use for medical purposes, face shield, and gloves. Once the masked patient arrived in the operating room, the wet gauze was placed over the nose and the mouth, and therefore some degree of protection was there. We had a mask and viral filter. Over the last 1.5 years, we've been using rapid sequence intubation and the video laryngoscope exclusively for intubating patients. Bag mask ventilation is avoided to the strictest degree, and we had low flow maintenance anesthesia, preferably with total intravenous anesthetics. As far as the monitoring is concerned, we had a continuous monitoring of patient vitals, including the end tidal carbon dioxide, which gave us a very clear idea of the ventilation as well as the other parameters of the patient. Now, this was another innovation which we had to incorporate into practice. And this is a clear acrylic intubation box, which has been used in the operating room. But as the literature would tell you, the ergonomics of this box remain completely undefined. It needs practice to be done. It cannot be done on an emergency basis. And therefore, we had dummy runs and simulation exercises before this can be effectively put into practice. We also defined an indigenous method to avoid aerosol contamination at intubation and extubation. So one of the most important things which happens for inadequate anesthetic planes is cough. And that was prevented by a deep plane of neuromuscular blockade, intravenous lidocaine, propofol. Minimal tube disconnections and suctioning only on an SOS basis. All equipment and surfaces were cleaned with antiviral disinfectants like ethanol, hydrogen peroxide, or povidone iodine. Now, as far as the anesthesia equipment for COVID-19 is concerned, we had a COVID-19 designated trolley, which we gathered from the literature, as well as a backup trolley for emergency situations. One of the most important questions, one of the most thorny questions, is whether to extubate the patient at the end of surgery or not. All non-anesthesia personnel were advised to leave the room during the process of extubation of the patient. PPE for staff was provided. Coughing at the end of anesthesia was strictly avoided. Wet gauze spaced over the mouth and the nose at extubation. An N95 applied with the low flow binasal cannula. And if the patient was not extubated, as often happens in neurosurgical operations, the patient was sent to the intensive care unit with a pain circuit to the handover team with viral filters. But there are some special conditions for pediatric neurosurgical patients. We avoid nasal pre-medications. Intravenous induction of anesthesia is preferred. Inline closed suction catheters were used. We extubated deep, and TIVA was used for a significant number of cases. But there are so many combinations in pediatric neuroanesthesia and neuroanesthesia per se, which immediately call for innovation of the operation in the operation theater. You had an infected patient and a non-infected mother. You had a non-infected patient and an infected mother. You had an infected father, a non-infected mother, and an infected child. So the combinations were endless. And therefore, it called for immediate innovation in the operating room. As far as the post-operative management is concerned, the hospital has a designated COVID recovery areas, surgical mask N95 in all cases. And for people who require post-operative respiratory support, a non-rebreathing mask, helmet NIV, early re-intubation for actively desaturated cases. And despite knowing everything, there are many unknowns in these combinations. As far as interventional neuroradiology is concerned, only emergency cases need to be done. Minimal anesthesia care or monitored anesthesia care for airway management, cleaning up of surfaces with virucidal agents, and rapid and safe transfer of the patients to COVID areas. Now, there are so many dimensions which are still gray in patients with COVID-19. How to manage an awake craniotomy? What about the concept of a regional anesthesia with neurosurgery? What about the pregnant patient undergoing neuroanesthesia for a brain tumor? What about post-operative care and rehabilitation? We don't have black and white answers. We have only gray dimensions to these unsolved problems. And when we don't know the road ahead, the road always diverges. It breaks into two different paths. And believe me, it has a fantastic psychosocial dimension, which all of us have faced over the last 2 years. The psychological status among anesthesiologists and operating room nurses in the outbreak of COVID-19 in Wuhan, where it all began. Incidents of anxiety, incidents of depression, incidents of helplessness, incidents of uselessness have increased tremendously in all operating room personnel over the last 2 years. It's been a slow pandemic of the COVID causing the mind to break down. It's been a mind-breaking story. It's been a heart-breaking story. Occupational stress and mental health among anesthetists during the COVID-19 pandemic. Too much workload, lack of family time, lack of sleep time, claustrophobia, physical illness. The list is endless. The consequences are devastating. And if you don't have a healthy caregiver, what sort of a healthy patient would you exist? Professional fulfillment, burnout, and wellness of anesthetists during the COVID-19 pandemic. This was published in the CanJan. Again, the same results. There have been a tremendous burnout, a tremendous fade out of people who have been forced to leave the operating room and work in COVID units. There have been stories of anesthetic machines being converted into ventilators for sick patients. Stories which have grabbed the headlines time and again. And we've had poor sleep, patients with tremendous anxiety, alcohol abuse to the point of suicidal ideation. And if this does not hurt the mind, what will? We're looking at a story of glorious uncertainty. And yet, despite all of that, we've had to look at the financial stability of the practicing anesthesiologist like me, who's managed to keep his head above the water despite all what life has thrown at me. And this is a closing slide from Professor Martin Smith from the world, one of the figures whom we all revere. Just as the world will be irreversibly changed by the pandemic, many aspects of healthcare will also be different in the post-pandemic era. We have to change the way we look at neuroanesthesia. We have to change the way we practice neuroanesthesia for critically ill patients. We have to change our personal lives. It's a change which will come from deep within. And as this business marketing slide would tell you, there are no knowns. We know how the COVID virus behaves itself. We know how it attacks the cells. But there are known unknowns. So the medicines which we use for COVID, what are their anesthetic considerations? We don't know. We know, but we don't understand. There are unknown knowns, things which we understand, but we are not aware of. How does COVID affect the brain? How does COVID affect the long-term survival of pneumocytes and neurons? And there are unknown unknowns. The most brilliant question which emerges on this unknown is when will this pandemic end? So we have to deal with all the 4 quarters of this unknown unknowns grid. But of course, in this brilliant uncertainty that we have, as Carlos Castaneda said, we have to balance the linearity of the known universe with the non-linearity of the unknown universe. And this is the WHO data, which has emerged on the 31st of December 2021. An alarming 11% increase in the number of COVID cases, particularly of the Omicron variety. And as of 26th December, ladies and gentlemen, 2021, as we step onto a new year, 278 million people across the world have been affected with the COVID epidemic. A chilling reminder. And just under 5.4 million people no longer exist because of this tiny, invisible enemy. We have to readjust our lives, our professional existence, and our personal well-being to fight it. I bring you greetings from Kolkata, and have a healthy and safe 365 sunrises ahead. Excellent gathering. Thank you for your time.